Gaurav, do let me know whenever we'll be live.
Sure. We are live now.
Sir, you have to start your video. Yeah.
I'm there.
Hello, everyone. Welcome to Global Interdisciplinary Summit. I'm Dr. Jasmine Mirwaha, co-founder of Global Outreach Medical and Health Association, Global Outreach Forum of Endodontics, and Global Outreach Journal of Dental Research and Education. So today I'm back with another renowned speaker, Dr. Sandeep Singh. Talking about him, Dr. Sandeep Singh is President and International Board Member of World Academy of Ultrasonic Piezoelectric Bone Surgery, Southeast Asia. As Director of Dental Health and Sciences, Sam Higginbottom University of Agriculture, Technology and Sciences, Allahabad, India, he works to develop and promote piezoelectric bone surgery and growth factors and on organizing conferences, lectures, and workshops on vertical and horizontal 3D bone augmentation procedures. Dr. Singh graduated in university from Amravati, India, completed his residency at AIIMS, New Delhi, and his mastership in implantology at UCLA. He is also a certified trainer for endodontic procedure from Mellifer Institute, Dentsply Sirona, Switzerland. So today, he'll be going to talk about very important topic for clinicians, that is do's and don'ts, anterior aesthetic zone. So before moving ahead, I would like you guys to register yourself for CE at www.gomha.org. The participation certificate will solely be presented to all those who are compulsory a GOMA member. If anyone is not having the GOMA membership, kindly register for it. And we will share a link containing a form which has to be filled in between the sessions. The form will be valid for 2 hours after the session ends. And the form will be a unique proof for the participant attendance for a respected session. And after the submission of the form, the certificate of participation will be directly posted on your email address within 7 to 15 working days. Thank you. Over to you, sir.
Yeah, hi. Thank you so much for giving me this chance to be here on Global Summit, and which is being co-hosted by Global Outreach Medical and Health Association. And I would like to thank my dear friend and brother, Dr. Kianor Shah, who got this idea to create this global summit, interdisciplinary summit. And I'm really proud of this fact also that I'm one of the board members, along with a very famous surgeon from India who has been there in US for a long time, and he has done a lot of work on growth factors, Dr. Arun Garg, and all other my dear friends over there. So I'll not take much time on all these things. I welcome all of you for this summit. And there are a lot many other speakers today. And mainly Dr. Arun Garg and my dear friend from Russia, Dr. Samuel Blier. So today I'm here in front of you. I'll be talking about do's and don'ts in anterior aesthetic zone. And let me tell you, I've been very much inspired by in my journey of implantology from Dr. Lanka Mahesh, my brother, and he has been my mentor too. And then when I did my UCLA, it was under Professor Sasha Jovanovic and Professor Istvan and Professor Egon from Italy. So these three people were the one who shaped me, and that is why I'm here. And in this journey, again, I met Professor Dong Seok Son. I call him Master, and he made me go into the growth factors and piezo surgery. And then Professor Daniel Boozer, I'm very closely associated with him, and we do a lot of programs, and I'm bringing him to India. And Professor Patrick Palachi, the famous Palachi technique, and Zeev Major, Zeev Simon. There is an endless list of names. Those people who have been inspiring me, uh, like Scott Gans, Dr. Scott Gans from US, and Salah West, and Dr. Morris Salama. So I'll be talking, let me tell you, this anterior aesthetic zone is very, very uh, sensitive area where when patient comes to you, you need to know what you are supposed to do and what you are not supposed to do. And this lecture of mine is more inspired by Dr. Joseph Kahn and Dr. Dennis Tarno, because these two people have done amazing work into this anterior aesthetic zone. And until unless you know that what they say and what are those things which you have to take care, um, do not try placing implants into anterior aesthetic zone. I am also associated with the PG diploma program from UCAM, University of Murcia. I'm one of the faculty member with my friend Dr. Lanka Mahesh, who has initiated, and Dr. Praful Bali, who has initiated this program. And this is the first batch from India with my team, colleague, Dr. Chakshwesh, Dr. Vaibhav, who's not here. So I'm really proud of this fact. And this is me. I've been introduced, so I don't want to take much time. So just let's come down to do's and don'ts in anterior aesthetic zone. What what do we want? We need to see this. And what we need is something like this, where we need to have symmetry, we need to have the zenith, we need to have the 100% papillary fill. And when the patient goes back from your clinic or surgery, you just don't want that anybody should say anything to the patient. Oh my God, you're coming from the, have you been to a dentist? Have you got something done? If these kind of comments are gonna received by the patient, that means there is something wrong with our treatment. Because whatever you have done, you have to mimic the nature. So that is very important. And what we don't want, that is also very important to learn. And in this, you just don't want something like this. And I clearly remember that uh, Professor Joseph Kahn, he has one lecture which is showing the anterior aesthetic zone implant placement, which he had done more than 20 years back. And I still remember that the patient of his patient was from India, and she came down to him, and finally she entered his clinic maybe after 20 years, and she said that there's something wrong, and I could see my implant visible. So why it happened? That's very important. Why it happened? What was the reason behind that? That the implant diameter, which was taken into account, was not right. The implant angulation was not right, and there was no bone mapping done to see the buccal bone, what was the thickness, and the soft tissue thickness, the biotype, and the phenotype, everything. Like this is a classical case where you can see the peri-implantitis, which has happened maybe along with loss of soft tissue and the bone tissue and a dark triangle. So this is not acceptable. This is what we just don't want. A condition like this is a classical case of peri-implantitis, which has happened. And when we talk about peri-implantitis, basically it is, I believe, that the biggest reason of peri-implantitis is occlusal load. If it is not proper, definitely patient is going. Then comes down the other factors comes into the consideration. The biggest one is the micromobility, the perimucosal seal, and the kind of implant which has been used, the surface, and micromobility plays a very great role. So that is why I always suggest that try to use the conical connection, which are more near to the more taper connection, because if you go through a video by Ziprish, where it has been clearly explained that those uh, hex connection, where they have this micromobility, and then they have this pumping action, and because of that, you get the bacterial plaque flowing down into sucked up into the implant and the abutment interface, and that can create a bacterial plaque accumulation around there, and that leads to mucositis and then implantitis. So in this condition, how you are going to treat, I normally ask the participants that how you're going to treat this condition, because it seems to be not a screw retain, it is a cement retain process. It's not my case. I'm just showing it to you for the uh, uh, showing you for this um explanation that uh, uh, I hope the presentation is going live. Everybody can see the presentation. Uh, so in this case, I would prefer taking it out.
Sir, you need to share your screen.
Screen is not being shared?
No, sir, it's not.
Oh my God. Just a minute.
All right, sir.
You never prompted me. Is it visible now?
Yeah, yes, sir. Yes, sir.
Should I go back again?
Yes, sir. You have to, sir.
Yeah, because now it is visible.
Yes, sir. Perfect.
Yeah. I'm sorry, my screen was not being shared, so I'm really sorry for that. But here we are with the Global Interdisciplinary Summit, and I thank Global Outreach, Medical and Health Association for co-hosting this program. And today's, after my lecture, we are going to see here Dr. Samuel Blaine and Dr. Arun Garg, and I'm really thankful. I told everything, so I'll slowly go back to my presentation because I have already talked about what is the do's and don'ts about anterior aesthetic zone. So what we want, something like this. We want the zenith to be proper, to proper alignment, the papillary fill and everything has to be right. And we just don't want, this is what we just don't want. A condition like this. So I talked about this situation, and I was talking about Professor Joseph Kahn showing his presentation like this, and his whole presentation is based on one single case, which is amazing. He's the master, he's a legend there, and I'm pretty much inspired by him and Professor Dennis Tarnow, because we are going to discuss uh, their classification into this. So I was talking about this situation when you get the peri-implantitis and a patient comes to you like this. So what to do? Would you like to take out the implant and do a JBR proper, go for a proper GBR, wait for 6 to 8 months, and then re-enter into a proper prosthetic position? Or if the patient, because this is a partially integrated implant, so many times, especially when we talk about Indian uh, situation, in India, patients are like very difficult. It's very difficult to make them understand. And they may say that no, you have done it, or if somebody else has also done it, it seems it's not moving, everything seems to be fine. So if you can do something, try to save it. In that condition, I last year I came across a lecture in University of Bern, the third symposium, international symposium, which was organized by Professor Daniel Boozer and the team there. And Professor Frank Schwarz was talking about peri-implantitis. And if you have to take care of it, it seems to be a cement-retained prosthesis. So you have to make a hole, take it out. Take it out so that you can clean 360 degrees around. And for cleaning, for this kind of situation, what I believe is there are only two things. One is hard and soft tissue laser, where you can decontaminate the surface of the implant. And if you do not have that, then definitely the titanium brush. The titanium brush, I would prefer cleaning it up with the titanium brush. And then I can use clindamycin slurry or something to decontaminate the bone around uh, for a few minutes. I leave it there, tetracycline slurry or clindamycin slurry, and then wash it out with chilled saline. And then I will not go for any other site. I will utilize the site which is there. My working site becomes my donor site because I like to have those disposable bone scrapers. If you have Boozer scraper, you can reuse it again and again by autoclaving it. And I would like to scrape the cortical shavings from that area around, designing a larger flap, and scrape it up and collect that autogenous bone, and little bit of, if I use a lot of growth factor, so I would like to place it into the growth factor IPRF, and then the little bit of the blood of the patient and create the coagulant with the saline. And it is very well explained and researched by Professor Istvan et al. And he says that when you use this cortical shavings, it is in his research work, it has been shown that a lot of growth factors are being released. So that coagulum is very, very important. And then when I have to do the grafting, I will allow that, I'll take that um, cortical shavings and then pack it around the implant. And then on top, I would like to go for a xenograft, especially the demineralized bovine bone. And I go for the contour grafting, which is very well explained by Professor Daniel Boozer, and then put the membrane and close it. And sometimes we have to enhance the biotype. We have to see what kind of thickness the soft tissue has. So you have to incorporate CTG, or you can use that PTCTG, pedicle tunnel connective tissue graft, in single stage from the palatal side, and then close it down and suture it and give a temporization into that area and wait for a few months so that a good coverage and newborn formation happens. And then you can design the prosthesis. So this is the way I'm going to treat cases. And as the world is going, especially in India, everybody is placing implant. So I believe the biggest epidemic is going to be in India. It is basically the caries, uh, uh, dental caries, and periodontitis. But down the line, 5 years, I believe it is going to be peri-implantitis. So if you are not aware how to treat the peri-implantitis, you become the rehab dentist if you know this. So let us talk about the current scenario. This is what we get. It's 43% cases we get perimucositis. And why perimucositis? Because this perimucositis happens because of there is no perimucosal seal we have never tried to create. So there are, as I said, that there are companies in India, especially two of them, they have come up with a tissue level implant, but and that is like you get it in Strawman, but in anterior aesthetic zone, it may create some problems. So in that case, Nobel Biocare has come up with on-one uh, abutments, where you can convert your bone level implant into a tissue level implant. So you place your bone level implant into the bony housing, because that's the most important thing. Your rough surface should not be exposed to the soft tissue. And then you can add on the on-one abutment on top of it and close it. So later, when you are going to put the gingiva healer, gingiva healing abutments, or the prosthesis abutment, you are not disturbing the perimucosal seal, because it gets a connectivity to the implant surface, to the abutment titanium surface, just like a normal tooth. And then that disturbance, if it is not there, you prevent the perimucositis chance. Another thing which is quite disturbing in implant and dentistry, because if you see, there has been a lot of discussion about placing implant that try to save your tooth, the patient's tooth, as much as you can. Even if you have to go for a uh, um, uh, crown lengthening procedures, you have to get it uh, in, uh, extruded. You by the help of your orthodontist, you can extrude the roots present there and go for an endodontic treatment and try to do a post and core and preserve the natural tooth, which is being told by recently into one of the discussions by Dr. Otto Zuller and Zur Academy. They have started advocating that you try to save as much as you can. If there's no way out, then you should go for the implants, because peri-implantitis is the biggest epidemic into dentistry, which is we are going to see later, until unless we do not create a conducive atmosphere, building up the soft tissue and the hard tissue. Do not try to place the implant, because this is the worst thing which happens when a patient comes back. Why I'm saying this? Because your patient is like, the moment you place the implant, you marry your patient. You know, they start behaving like those uh, nosy wife, like they come, this is loose here, it's moving here, there's some bleeding here. They'll sit on your head and they'll start plucking your hair. So you have to be, so this is the 22% chances, prevalence is there for peri-implantitis. We should not come down to a situation where and as I said earlier, the peri-implantitis, the biggest reason is occlusal forces. If it is not proper, if it is very high, your patient may end up into losing the bone. And if you lose the bone, you're going to lose the soft tissue, because hard and soft tissue is just like husband and wife. A good uh, boyfriend, girlfriend, or husband and wife, they keep on complementing each other. If they don't do, there is a discord, you end up into the divorce. So let us come to the another aspect, is how this is, the peri-implantitis is defined. Is bleeding on probing, the periodontal attachment, the depth, and if we see the pocket, how deep is the pocket. So these are the ways which you can make out that a patient is undergoing the clinical aspect. But then you have to correlate it with the CBCT and the radiographic images also. So when we are talking about the anterior aesthetic zone, we have to think about these case selection and planning. It is very, very important. You have to have the diagnostic CBCTs, and you have to, if you have a scanner, which is very popular now, and most of the clinics, they have a digital scanner. So when your patient visits you, in the first meeting, if you take a scan, it'll help you in planning the case. And then in anterior aesthetic zone is atraumatic extraction. I will never say, it was initially written down atraumatic, that any extraction is a trauma. So least traumatic extraction. So I'll tell you what instruments which I use for this least traumatic extraction in the anterior, so that I can save my soft tissue and hard tissue. And then immediate implant placement. Now the ITI has changed the norm that the immediate implant placement, until unless everything is fine, uh, we should go for a early implant placement rather than immediate, so that you let the soft tissue grow on top of it. Uh, it becomes good, and then you can re-enter within 4 to 6 weeks. But it has to be more palatal. And when you are doing this immediate, then degranulation of the socket is very, very important. And I personally believe that I would like to degranulate with a burr, with a diamond burr at a slow speed, because I would like to take out the bundle bone there, because this bundle bone is ultimately going to dissolve. So I scrape that area. I do not want any kind of high osteoclastic activity into my newborn formation area, because there'll be a lot of remodeling, and that could lead to macrophages and a lot of osteoclastic activity. So these points are very important. And we should know that the implant thread should not engage the buccal bone plate. So buccal bone mapping is very important before we think of going further. And another very important aspect is implant should be 3 to 4 millimeter below the CJ. And this is possible only with the conical connection, not with any other normal hex connection. So all those systems which has conical connection, and I do place a lot of most of my systems which I use, and I believe the best in this category are Ankylos and Megagen Eneridge. It is one of the best implant systems which I have with 5 to 6 degree of connection. Now we have to think about the concept of biological breadth. You know, as per your normal tooth, they have this at the CJ, the connection, and the soft tissue, the bone. You have to think about your implant, and that is very important. So this 3 rule is very important. When you are placing your implant, you have to plan accordingly, that if your soft tissue thickness, you have to measure your biotype. Your biotype gauging, and you have to understand that how much is the bone. Like if your biotype is thin, you have to have at least 3 millimeter of soft tissue on top of it. So if you do not have that, sometimes you can do that. Like if I say that if you have a 1 millimeter of soft tissue on top breast, you have to create soft tissue. You have to go for a soft tissue augmentation side by side. But if you have 2 millimeter, if you do not have 3 to 4 millimeter of soft tissue on top, 3 millimeter, then what you can plan is taking your implant more subcrestal, so that you get this geometry of, you know, you have to understand that 1 millimeter of sulcus, 1 millimeter of epithelial attachment, and then supracrestal area. So this part of soft tissue, you have to think about, and then do the mathematics around there to have your implant placement as per the situation of your soft tissue. This is very important. And this is one picture with I have taken by the permission of my very good friend Alberto Mistelli, where he has explained it very nicely with this implant analog and this abutment interface, 2 millimeter of the soft tissue attachment here, and 1 millimeter of sulcus, which you have to maintain. So it's a very well explained photograph into this here by Dr. Alberto Mistelli. And now, if you see, here it is the biology versus engineering. So you have to create the soft tissue. This is a normal tooth where the connective fibers, uh, connective tissue fibers are connected over there. It is very well known that the implant surface, the smooth surface, not the rough surface, they developed a connection with the connective tissue. So you have to keep that in consideration. That is why these tissue level implants have come more now coming back again into the thing that where you have to. Because when you use a normal implant, which is a bone level implant, whenever you take out the healing abutment, you can see a slight oozing of blood into the emergence profile of the soft tissue. And that is a healthy bleeding from the hemidesmosomes because they have got connected to that part. So when you remove it, you lose the connection. But when you have this tissue level implant, you create a perimucosal seal around it, and which is not at all disturbed, and your uh, rough surface is below that. So you have to keep this thing in consideration. And now I'm going to talk about the guidelines of aesthetic zones. So we have to think about low, medium, high. Low is the green zone, which is like you are perfectly all right with that if your patient comes into this category. Medium is like you have to manage, and the high risk zone, the red one, is like it's a high risk zone. So you have to consider a lot of things. You should never with these kind of situations, you should never go for immediate placement. So we are going to talk about the medical status of the patient, smoking habits, patient's aesthetic expectation, lip line, gingival biotype, shape of tooth crown, infection at implant site, bone level at the adjacent site, restoration status of the neighboring tooth, width of edentulous span, soft tissue anatomy, and bone anatomy, phenotype and uh, biotype. So these things are very important. Let us talk about smoking first. The medical status, as we say, you have to be very careful about those people who are diabetic, and you have to go into check their status of blood sugar, the diabetic status. You can place implants into a controlled diabetics, and there have been instances where I have heard people placing implants into patients who have very fluctuating uh, diabetic status uh, with the peaks going up and down. So in those cases, they have advocated that they have advocated one thing that uh, your loading time should be delayed. What if we load the implants in 3 to 4 months, 3 months, 2.5, uh, 12 weeks, 16 weeks? In diabetic patients, you have to increase that time period. And then comes your smoking. Uh, a strict no-no from all around the world. Everybody talks about this, that ask your patient not to smoke because um, the first thing is the nicotine. And when patient smokes, it creates a negative pressure inside the mouth, in the oral cavity, and that can dislodge this clot. And that is very important for us. And another thing is the heat produced. and it delays the nicotine delays the healing. So all these factors are very important, but the data present over these days is not much. It's kind of insufficient. And let me tell you, in few of my cases where patients were smokers, I have placed implants and they are doing well, but that doesn't mean that you can allow your patient to go for smoking. Always tell them not to do that. And if they can leave it, it's much, much better. Then comes your aesthetic expectation. I mean, this is something very funny because what I have seen that patients, they have very, very high uh, expectations. As you can see, they want to be like this, but in reality, they are like this. So never ever give your patient a very high aesthetic expectation after that, because when they come to you, they are already high on the expectation. So try to tell them that look, this is this is something I'm trying my best to mimic the nature. Uh, I cannot be a god. So that is very important. And in India, definitely patient comes down and get one implant placed, and then they expect that it is gonna last for lifelong. Uh, there's nothing like that because I remember a very nice saying by Buddha that there's nothing permanent in this world. So tell your patient that I'm trying my best to make my the treatment and my surgery so that it lasts for 15, 20 years, 25 years. But you have to you have to have your you have to get your compliance from the patient also. So regular follow-ups and any kind of problem happening, you can rectify in that period of time. That is also very important. Which in India normally patients never do that. Now comes your consideration for the lip line, which is very, very important. A high lip line and a medium and a low lip line. So in low lip line area, you are into the greener zone. If there is some discrepancy into the soft tissue, the zenith, even at the widest grain, it's not visible. Here you can manage, but this you have to be very critical, very, very careful about this kind. And to get this high lip line patient into a low lip line, there's one modality which you can do. You can ask your oral surgeon if you cannot do it, for lip repositioning surgery. So that is one thing which can make you hide your um, faults. But that's not the right thing to do. The gingival biotype is again very important. And when your patient comes to you with a long elliptical kind of tooth, you can make it out that this patient has a thin biotype. But if the patient is coming to you with a squarish kind of tooth, then you can make it out that it is going to be thick. But then you have to understand that you have to assess the biotype, which is very, very important because your soft tissue is going to maintain the hard tissue, and you have to have a thick biotype where you are placing implants. So that's very important. And then comes the shape of the tooth crown, which is again very important because this is one of the most important, the 5 rule, which has been told by Dr. Dennis Starno. And if you do not get this into consideration, you may end up in trouble. So this 5 is like from the embrasure area, your bony peaks are where? Of the adjacent tooth. If it is within the range of 5 millimeter, which is almost 98% cases, you you don't end up into something which is like you may go into a crisis situation. So most of the patients they come into this category, but you have to make it sure with the CBCT where is the bony peak. So it is 5 millimeter, it's fine. But if it is 6 millimeter, you are in little trouble. And if it is more than 7 millimeter from the contact point, so here you have to make it understand that where you are going to place your implant, and these are this case, the third category, 7 millimeter. Uh, you may end up with dark triangles because whatever soft tissue augmentation you do, it will not be there. There will be no gingiva which will creep into that area. You have to keep your contact points higher, or you have to do some vertical augmentation and then place the implant. That is very important. And this is by Dr. Dennis Tarnow. So this is one case of mine where I have placed, this is a Cortex Dynamics conical connection implant. And you can see my bony peaks are where, and my implant is more than 3 to 4 millimeter below the CJ junction. So why I'm doing this, because even in this case particularly, my patient was in a lot of hurry, and there was no diagnostic CBCT taken out. So I had to depend upon my clinical skills. So when I took out his fractured root, then I palpated the buccal bone, that what is the thickness, if is there any fenestrations. Luckily there was no, but normally 60% cases you get fenestration. So so in this case I placed an implant. And always remember, when you are dealing with the anterior aesthetic zone, never ever go beyond 4.0 millimeter diameter of the implant. The slender implants are much better than the wider implants. So wider implants are not for anterior aesthetics. So this is one case which I tried to show you, and here you can see immediately I gave him a temporization with a single stage surgery, and you can see I preserved the papilla, I preserved the soft tissue, the gingival keratinized soft tissue around here. And you can see a 12 weeks follow-up after. Then when I had to go for the loading, and I wanted to see how I had placed. And there you can see this was a freehand placement, but it was exactly into the triangle where we, but what I missed in here, I would like to tell you that the bone mapping which I was talking about is this bone mapping is very important. What is the thickness of buccal bone where you have, and your implant should be more palatally placed. In this case, I should have gone little more, 2 millimeter more palatal, because this was freehand surgery. There was no template, or there was no guide into this. My distance from the implant threads to the buccal bone was 1.34 millimeter. It should have been, it has to be around more than 1.5. If you do not have that kind of distance, the jump space has to be 1.8 to 2 millimeter. If it is less than that, it is very important by Choppy et al., Vivian Choppy et al. She has a study along with Professor Daniel Boozer that if your buccal bone thickness is less than 1.5 or 1.8, the critical thickness of buccal bone, then you have vertical bone loss, which may end up into more than, from the crest to apically, 7 millimeter. So you have to take this into the consideration. That it's very important to have that jump space. And if it is not there, then you have to go for external veneer graft. So this is what I was referring to. The bundle bone will resolve within 8 weeks after tooth extraction. So I try to remove that, Chen et al. And in case of thin fascian bone wall, which is less than a millimeter, a median vertical bone loss of 7.5 millimeter has been observed into the anterior maxilla, and it's a CBCT study by Choppy et al. Then this is what we want, the 100% papillary fill, which I was talking earlier. Now, uh, let's talk about the infected site. Many people raises this question that if the site is infected, can you place an implant? Definitely. It can be placed because the studies by Gwender, by Picora, or by Marcocini, they have shown 89 to 98%, 100% success rate into the areas which have been infected areas and they have placed implant. But the prerequisite is that you need to decontaminate, degranulate that area. And as my very dear friend Zeev Simon, a periodontist from USC, University of Southern California, says that which is the best site to graft, and he says that the best site to graft is the infected site because of high vascularity present over there. But definitely, again, the prerequisite is to decontaminate, degranulate, and clean up that area. And then if you do the grafting and implant placement, success has to be is there. So nothing to worry about that. Implant positioning is very important when you are placing as per the ITI norms. If you see, you have to consider the 5 rule, the biological width, so that 3 and a 3D positioning, your more palatal implant placement. So this is very, very important. You have to take these things into the consideration. And the ideal jumping space, as I said, has to be between 1.8 to 2 millimeters. Your implant thread should not touch the buccal bone because they are the most vulnerable. Look at this situation, which has been nicely explained in videos. But the implant engaging, what we do, we generally what we do is we take out the tooth and we go into the socket, and we do not engage the host bone more palatal, and your implant is touching the buccal bone, but your prosthesis is in a proper position. But what happens? The patient will come back to you losing the buccal bone. So this is not the right positioning. You have to remember this. Look at the second situation where you have placed, try to engage your implant apically, but again, the implant, many people have experienced this, that they have gone deep, and at the time of implant placement, when they inserted the implant, uh, they could find that the position was exactly right. But then when they gave the final torque, implant drifted, buckle, more buckle. So suddenly they find that the position has changed. Why that happens? Because of the dense palatal bone where the initial osteotomy has not been done, and that has not been engaged. And because of that, your implant shifts. And then again, you are in trouble. Your prosthesis may be into the right position. The ideal position is when you have engaged the buccal bone into the palatal host bone, the implant into the palatal host bone, and you have chosen the implant which is little longer than, so here in anterior aesthetic zone, it is always good to have a longer implant more than the size of your root. So always measure that and then choose a longer, whether it's 13 millimeter or 15. And let me tell you, in anterior aesthetic zone where normally I have to do immediate placement, I try to engage the implant apical area into the nasal floor, a bicortical engagement to give more and more initial stability. And you see the site, the jumping space has to be in the range of 1.5 to 2. If it is more than that, then you have to go for internal veneer grafting. And if it is the buccal bone thickness is less, then you may have to end up with a external veneer grafting. This is my case where I have placed the implant, and you can see a nice soft tissue contour which has been maintained immediate, and you can see 2 millimeter jump space ideal. And it was a correlation for this. This apicocoronal positioning is also very important. Scott Gens talks a lot about this, that when you are inserting your apical and coronal positioning is synchronized or not. So for this, I have shown one of my cases here. I have used a Magix implant from, this is Cortex, and you can see the final placement where you can see the apico-coronal positioning. It is a free hand. Look at the parallelism also. And this is the final single stage implant placement. And I give a temporization onto that with a um, prosthesis which is not touching the implant, because the bone quality was not good. Now the neighboring tooth is very important. Like when a patient comes to you and if you have a visiting orthodontist, he will always ask you to go for something like clean the teeth, the oral cavity, oral prophylaxis has to be done. If there is a cavity, that has to be filled. If there is a deeper cavity exposing the nerves, then the root canal has to be done, a proper crown has to be given, and then he starts the treatment. So similarly for implants, when you're talking about these things, any infected site or any, you have to correct that. And it has been now in researches, it has been shown that people who have periodontitis, they have more predilection for uh, developing peri-implantitis. So you have to do that if the adjacent tooth has to be uh, properly uh, taken care of. The bone anatomy, one has to be very careful about this. Most of the cases, 60% cases, you get fenestration at the time of extraction and implant placement. So if there is a fenestration, then you have to go for external veneer grafting and you have to place something here. When you are going for a flapless, it is very difficult. So then you do internal veneer grafting. But if it is a bigger defect, then you have to raise the flap. And then in that case, I believe that you have to take out the autogenous bone shaving and whatever area which has been exposed, the implant rough surface, that has to be covered with a autogenous bone, and on top of that, demineralized bovine bone. It's always better. Uh, it's osteoconductive. It maintains the contour. The contour grafting has to be done because we just don't want, as per Boozer et al., we don't want this outer area to get resolved. It has to remain like that because it will maintain the volume. So if you have the sufficient coronal bone, then you have to do the grafting, and it is very, very important if there is a fenestration, or else your patient comes with a dehiscence defect. Sometimes what happens that you have a sufficient labial bone, but there's still a concavity is there on the soft tissue, and Professor Zucchelli has explained it very nicely that in these kind of cases, you do not have to go for a hard tissue grafting. Then you can use a CTG, or you can use an alternative to CTG, which is CGF or APRF or a mucograft, I have seen, or alloderm or mucoderm. And then you do a tunneling and engage your CTG or the alternative, and then pull it up and augment that area. Uh, and always remember that when you are augmenting anything, soft tissue, hard tissue, stabilization is very important. So many times you have to combine your hard and soft tissue. And then comes the most important aspect, the sagittal root positioning, which has been given by Professor Joseph Kahn's classification. If this is type 1, if the root is positioned against the labial cortical plate, this is the most suitable sagittal position where you can place an implant after the extraction, because there is a considerable amount of bone onto the palatal aspect. This situation, the alveolar housing within the engaging either the labial or palatal cortical plates, so you have to go for, it may not be, the amount of bone may not be adequate, So in this case, either you go for socket preservation or you place an implant and you add on GBR external. So it cannot be flapless. You have to go for do the GBR simultaneously. In this case, it is type 3 where the root is positioned against the palatal cortical plate. And in these cases, it is always better to go for socket preservation, wait for a few months, and then go for a delayed placement. And in type 4, strictly no. You have to do a GBR, socket preservation, and GBR. You have to create a lot of bone and soft tissue around, because if this phenotype is thin, definitely your biotype is going to be. So you have to create bone, you have to create soft tissue, wait for 6 months or 8 months, and then re-enter. So this is the classification, which is very famous by Joseph Kahn. You get type 1, 81%, type 2, 6.5%, and type 3 condition is 0.7%, and type 4 is 11.7%. So this is by studies by Khan et al. And it's a very, very important aspect when you are trying to think about placing an implant. And that is why CBCT evaluation becomes very, very important. Now I'll be starting my cases quickly so that I finish it up. But when we are talking about immediate placement with grafting, then we have to think about biomaterials which are available. So it has to be bone autograft. I always prefer autogenous graft material with a demineralized bovine bone. I do not use much of bone allografts until unless I have to go for a socket preservation and early implant entry. But I use a lot of auto tooth graft, and that is by Cometa Bio. I have this grinder, the dentinal graft. It mimics, and you give a second chance to the patient's tooth, and it is the best part is autologous. So if you are taking out a tooth, a root stump, and you have to place, it's better to augment this with the dentinal graft. Alloplast, I don't prefer until unless you have to do some internal veneer grafting or early placement. So I use beta TCP to so that when there is a very thin space left and you have to augment that area, you cannot use a xenograft. So in those cases, you can, if you are getting an auto tooth graft, it is best. If you do not have, then and fast resolving alloplast. So this is the case one I want to discuss about. This was a case where patient was getting an endodontic treatment into an institution, and it was almost a year. And they kept on giving some treatment. They were not getting the results. This was a difficult case, a teacher by profession, so he couldn't go without the tooth. So what I did, I took an careful examination radiographic, and I could find that there was a midline fracture, horizontal fracture into the tooth. So I told him it cannot be saved, and I created a template. He never wanted to go without a tooth, so chair side option was given, immediate, and I took out this tooth carefully, preserving the soft tissue and hard tissue. And for this, I use this Benex extraction system, and which is very, very effective for anterior aesthetic zone because it takes out your root pieces without giving any kind of damage to the soft tissue and hard tissue. And this was the situation. You can see here, I preserved and I measured. You can see the host bone here. So luckily it was in type 1 condition. The sagittal positioning was type 1 type. And I never had CBCT at that time. So I was lucky enough to end up into a type 1 kind of situation. And I use a lot of growth factors. So you made the APR. And here you can see a wonderful osteotomy, which is into the host bone. And you can see clearly differentiate the extraction socket. So I did this, but at that time I never had those denser burrs with me. So because now I use denser burrs and I try to preserve the bone, expanding it inside and making the socket smaller. So this was the case, and as I said, it is very important. Palpation of buccal plate, rule out the fenestrations, which is almost 60% cases. When you are placing and you are not using a digital technology, then you always place the drill back, and which will act as a placement guide when you ask your patient to close your mouth. The jump space, as I said, has to be more than 2 millimeter, and implant surface should not touch the buccal bone. So here I filled up this part with a growth factor, and I did some grafting also. I placed the implant in the right prosthetic position. And when you are considering the implant, these four things are very important: the fixture design, the surface, the connection, and the length consideration. The tapered active thread design is very important for anterior aesthetic zone. SLA surface, most of the implants which are coming all around the world have an SLA surface. Conical connection is very important. The pure Morse is bicon, but the rest of them are like varying from 5 degrees to 13, 12 degrees connection, and length has to be more because I engage the and then initial I engage the bicortical region. Initial stability has to be very to be measured and very important. It has to be more than 45 NCM plus. But I do not only depend upon the initial stability. I use my ISQ values for implant stability quotient by measuring it by the RFA component of that, the resonance frequency analysis. And if my patient implant is showing more than 68, 70 ISQ value, then I prefer going for a temporization. So this is very important. If all those people who are doing, because sound-based loading is very hypothetical. So all those who are into implant practice, they should have these ISQ. And as a great line by Dr. Scott Gans, that do you ISQ? It's very important. Incorporate ISQ into your practice. Here, this implant was placed inside. You can see the jump space was more. This is an illustration by my big brother, Alberto Micelli, explaining how the implant has been shown and what is the design of the crown emergence and the jump space. And indexing is also very important. You have to remember, you have to match the flat surface of the internal hex from the buccal side. So it has to be parallel. And this is another picture by him, which I have been using it by his permission to show the right position of the tooth. And this is what I got in mind. So that was, and here it was grafted. At that time, I used a xenograft into this, a demineralized bovine bone. But now it is like we have to think about when you are doing like this, a flapless connection, you have to think about the bone implant uh, connection ratio, the bone implant interaction with the surface ratio, but how much bone is connecting the, so BIC is very important. And when you place this xenograft, because it's osteoconductive, there's chances of less integration with the implant surface. Normally it never happens. So in that case, the BIC ratio has to be taken in consideration. So you have to use something which, if you are within the range of 2 millimeter, you have to use something which fast resolving so that it converts into a new bone. A template, and then this was taken earlier. And then this was fabricated with a temporization material. And I had to add up to give the emergence, proper emergence to, because this is what it is going to decide on to the future prosthesis of that area. So I add up a lot of flowable composite, but then there are chances of leaching of the monomer when you are using a flowable composite. So when you do it, try to put it into a hot, place it for a few minutes into a hot bath, so that all the monomer leaches out, so that it is, because that those monomers are not good uh, for your soft tissue, because now they have this peak material, and you can get from the lab. But chair side, if you do not have a lab, in-house lab, then it is a trouble for most of the dentists. And I'm talking as per the perspective of dentist in India. So this was the final product. And here you can see good emergence. And this is what is important: indexing, bone grafting, mixture, 60-40. You have to sometimes use the connective tissue graft, CTG. And the initial stability has to be 45 NCM. And the design of your provisionals, they decide the future prosthesis. So that's very important. And this is what, never ever try to give them the exact matching. And these days, the the temporization material comes, they slowly changes the color so that your patient comes back to you, or they do not end, they normally end up coming back to you for more than one year or more than that. So here you can see clearly that how all the soft tissue and everything was maintained. De-occluded, it should not be in the occlusion. And this is what, at the time of, this was a cement retain, because the excess hole opening was coming up more facial. So I had to go for cement retain. But here you can see the grafting done, and subcrestal placement of the implant. And this is one at the time of permanent prosthesis. You can see the hemidesmosomes and a wonderful profile, emergence profile, and the implant and the crown. And there were this small suture abscess, which became a pain for me. But later I used the diode laser to make it heal, and it was healed properly. The zenith, you can see, was maintained, and the papillary fill was maintained. And patient wanted this diastema to be as natural. It was earlier also the similar kind of situation, so patient preferred that. And here you can see a 3-year follow-up. Look at this conical connection platform where the bone has grown on top of it. So this is what we need when we are placing the implant. This is not possible with a hex connection. This is second case. I have taken this term money tooth from my friend Steve Simon, and I took it out. Here you can see the extraction socket. Here you can see the clear-cut osteotomy and extraction socket. I used denser burrs into this to expand that, so that I don't lose the bone. And then ideal prosthetic positioning. And since the jump space was higher, I used a membrane to isolate that soft tissue from the grafted area, so that there's no ingress of fibroblast and soft tissue in that area. And then the grafting was, jump space was grafted, and a cola tape poncho was given on the temporary material, and then I used the patient's own tooth as a temporization. And here you can see, definitely I appreciate there'll be a shrinkage in the soft tissue, but when I went for this final prosthesis, I had to add CTG there. This was the condition. Definitely the tooth was not in a condition to be saved. This is my own illustration to tell you that how the implant has to be placed and how the jump space has to be grafted. And this was the temporization. You can see the bicortical engagement into the nasal floor. And we have a very good article with my dear friend Lanka and Dr. Sagarika Shukla that horizontal and vertical bridge augmentation in aesthetic zone is when you use xenografts, it gives you very good results. In this case, I used palatal roll technique. So why before that, I would like to say the whole implant, 13 threads were exposed. And I used titanium mesh here. And I use only on top of titanium mesh, I use just the APRF membrane. And I got very good healing. And then delayed placement into that, into the, after 3 months, 3 to 4 months, I gave a modified incision into that, and I took out this, and this was removed. And here you can see a wonderful bone formation and minimally invasive. So Tarno kind of, modified incision was given, saving the papilla here. And then gingiva healer was placed, and I utilized this much part. I de-epithelialized it and folded it inside, and that's called the palatal roll technique. So I just wanted to see that. And then here is a case where grade 3 mobility was there, autograft was used, where you can see the buccal bone loss, and I used a single piece implant into this area. And look at the placement. Indexing was taken care into the parallelism, and I used the bony shavings which were coming out, the auto bone graft. But when you place an autogenous bone, sometimes, most of the time, it is not necessary to place a membrane. But in this, I did place one membrane, a collagen membrane, and a closure. You can appreciate the parallelism, and immediately it was loaded. Temporization was done, and you can see 1 week post-operative healing, maintaining the soft tissue contour and the papilla. So this will give a very good emergence and for the permanent prosthesis. This is one case where I used a ceramic implant. Anterior Esthetic, it was failed endodontic treatment, was failed endo. Least traumatic extraction, I used this ceramic implant into this. And here you can see a wonderful contour, and the zenith has to be, and the soft tissue was maintained immediately after the placement. And non-functional immediate loading was done. There was no, and you can see patient was happy. And then see the CVCT. This is the ideal thickness which we need here. And no need to do socket shield. But I tried few of the cases I tried the socket shield, so I want to show it to you here. I have this root membrane kit from Megagen. So you do drilling, and then you take out the palatal root, and then beveling of the root membrane is done. And here you can see a Megagen implant was inserted 3.5, and you have to have this gap in between your root shield and the implant surface. Sometimes you can graft it, sometimes you just don't do anything. In this case, I never grafted. I took the ISQ values, it was almost 72, and I loaded it with the temporization. But here you can see that Tarnoff's classification 5 rule was not applied properly because this patient lived in Australia, and I had very little time to do the follow-up. So when he came back, he's still supposed to come back. So I thought my technician should have given a more contact point here so that the gingiva would creep in. But since follow-up was not possible, so these consideration has to be taken. But the zenith and everything and the soft tissue was maintained. And look at this what happened here. The root shield was extending beyond the buccal bone, which is, it should not be like this. You should not do like this. Your root shield has to be 2 millimeters below the buccal bone to save the bone. So this is very important when you're doing. And the delayed placement with grafting, there's few cases. This is one good case with a binary DM implant. A patient has this defect and a lawyer, so he never wanted to go beyond, in this case, papilla saving modified incision. And then here you can see the fenestration. So I used a little bit of autogenous bone and then a contour grafting with a demineralized bovine bone. And in this case, particularly, I never used any graft membrane. I used the APRF. And why? Because when you do a careful elevation of your periosteum, the periosteal flap, your periosteum sometimes acts as a barrier membrane. If there is no teeth. So that's the prerequisite. And this is the case. Slender implants, temporization, and here you can see a wonderful emergence. This is what we want into the anterior region. And look at the thick biotype which has been created here. And look at the band of thick keratinized tissue onto the buccal aspect. But there was a failure. And this failure was aesthetic failure because I was unable to get the papilla over here. And when I saw this patient after that, and there was a good papillary fill onto the laterals side, in between the laterals, but the midline. So I told my patient that because he never came for follow-ups during the temporization phase, so I said that I need to do some soft tissue surgery. And my patient said, look, doc, I was told by you, I never noticed this thing. And so I do not want to go for any further surgeries. And since his was a low lip line and he had mustaches, so I was a little bit safe, but he never agreed for that. So in low lip line cases, this is what advantage you have. And look at the 2-year follow-up, the contour grafting, which I normally do it in anterior aesthetic zone, which I've learned from Professor Daniel Boozer, that we just don't want this bone to be converted into an autogenous bone, because this will remain there for 10, 15, 20, 25 years, and there will be slow uh, uh, changes and remodeling and a new bone formation in between this. So this was a post-operative CBCT for uh, consideration. And this is one good case, last case, and I'll finish my presentation. Look at this kind of bridge, a delayed placement. And I have to tell my patient that I'm going to give you a zirconia crown here and a delayed placement. So a papilla saving incision, more palatal, saving the adjacent band of soft tissue, and the implant was placed. It was taken into consideration by closing mouth, but still, this in this case, I would like to tell you this is a normal hex cortex dynamics connection, and that I'll show you later that what happens. So this temporization was done chair side, and here you can see the implant was little more buccal. So that is why the facial the excess was more facial. So when we gave him the final prosthesis, we had to give the cement retain. But at that time, I created a chair side with the help of my lab guy, the temporary prosthesis, and this was filled up with a composite. And look at this at the time of implant placement, because I couldn't go more subcrestal in this case. And this was after the healing. Here you can see maintained soft tissue, pretty good. And then the parietal aspect, I took out the tooth, uh, the wonderful emergence. Here you can see, and abutment was given because it was a cement retain. The adjacent crown was prepared, and then finally we got this. which has a good soft tissue with a good keratinized soft tissue around. And I will try to show you, this is the low left line case, so it was wonderful. But here you can see, over the period, when the patient came back to me after 2 years, I could see a little bit of bone loss around here. If this would have been a conical connection and subcrestal placement, definitely the bone would have grown on top of it. But here you can see the abutment and the implant surface are of the same diameter. So the micro movements and that could lead to a little bit of bone loss around here. And this is, but aesthetically, 2-year follow-up, it was wonderful. You can see a very good papillary fill and a almost perfect soft tissue and a fantastic zenith. And the patient is really happy. Sometimes the peri-implantitis, as I said, when you have to do, and you have placed an implant, but you can see here the purulent discharge here, the sinus form. When you are doing these time cases, you have to, and the implant is totally integrated, and there's some area like that bone loss has happened, how to treat it. And this is the thing you can see here. I created the decortication done, and I cleaned this area with a titanium brush, papilla saving incision as the zucchini kind, and then decortication onto here. And in this case, I use BIOS collagen because this gives you a very good conversion on top. And I used a CTG, what do you call, an alternative to CTG is mucograft on top of it. And the closure was, the mucograft was given and the closure was done. And you can treat these kind of cases with nicely for when you get this kind of peri-implantitis situation. And thank you so much for your patience. And this is, I would like to show some slides. When I was invited as a speaker in WCUPS by Professor Dong Seok Son, who's the president of World Congress of Ultrasonic Piezoelectrical Bone Surgery. And then I became the organizing chairman. I organized in 2017 the World Congress. It was wonderful, from 20 international speakers around. And then the Global Interdisciplinary Summit. I go around in India also for my lectures. And then in 2019, again, I was in Amsterdam for Europe. And I'm one of the faculties in UCAM, which is University of Murcia. And recently I invited Professor Patrick Palachi to India for a one-day workshop. And it was wonderful. And now this year I was supposed to, we are seeing the COVID-19 situation. Professor Daniel Boozer, one-day workshop in India with hands-on. And I was unable to go this place because of COVID. And there was this Cortex experience in Israel. And I was unable to go. So thank you so much. And this is my email and my phone number and my city, Allahabad, with a holy confluence of 3 holy rivers, which is one of the biggest pilgrim for Hindus. And thank you so much. Namaste, and stay back home, stay safe. And I wish all the best and health to all of my colleagues all around the world. Thank you.
Thank you, sir. It was very informative and a wonderful session. So we have a couple of questions for you.
Yeah, please.
Question 1 is asked by Sushri. He asked, now we have, is it recommended implants placement in case of high diabetic and hypertensive patient? Because most of the practitioners in India avoid implant placement on these type of patients.
See, as I told you that patients who have systemic problem like diseases like which is most highly prevalent in India is diabetes. So if a patient is a controlled diabetic, we can definitely place them. There's no problem. But even in those cases where the patient is unable to control the levels, then you have to ask your patient to go back to his or her physician, the endocrinologist, and they can add up insulin or if it is required, or uh, raise the doses. And once that level is controlled, they can come back and get the implant. That's not a problem. But these prerequisites has to be taken care of.
Thank you, sir. Now, the second question is by Nishant.
Yeah.
He asked, what's your view on socket shielding technique?
See, socket shield technique, I believe that there are certain people who are doing it a lot, but there are two school of thoughts regarding that. If you talk about 35 years of experience of Professor Daniel Boozer, he never uh, he never agrees to that. He said, if why? Because when you are doing a socket shield, it is a technique sensitive. So you have to be very careful when you are cutting the root, and there's a lot of vibrations. And if that vibration, because of that, if the periodontal root shield, which is being attached with the buccal bone, if it gets detached in that process, you end up in most of the time failures. Uh, so if you are confident enough to do that, and I believe that I will always advise to do it in anterior maxilla, but not with the posteriors. I don't do it. I do a lot of regeneration procedures, GBR, and I believe that leaving a tooth part, because we have been taught since beginning that if you leave, have been trained by Sasha Jovanovic and Professor Istvan Arban, and all those people around Professor Daniel Boozer, Morris Salama, Dr. Morris Salama, and all those bigwigs, they always say, if you want to try some technique, first learn it, take a course kind or whatever you can. You know, just by seeing people they are doing it, they are experts into that. They have put a lot of efforts, like Dr. Otto Zur and Hazuler, they introduced this socket shield technique, but nowadays they don't do it. The person who made it popular, highly popular, is Dr. Howie Gluckman from South Africa, Cape Town. And then in India, Dr. Udat Kher does a lot of socket shield. Dr. Narayan does a socket shield. But Dr. Tarun Kumar does a lot of socket shield. So they have trained themselves for this procedure and they are doing fantastic. That doesn't mean that everybody can do it. And I personally believe uh, you need a lot of expertise onto that. So I prefer taking out the root and do the GBR, which is much more easier for.
Okay. Okay, sir. Now, the third question is by Shweta.
Yeah,
She asked you that what was that which you corrected with lasers in case one? Why did that happen?
yeah. Normally these days people are not uh, placing any kind of suture when you are doing an immediate placement, because they want a secondary intention of healing and they want to have a lot of volume. But at that time, because I had put I placed the APRF and membranes and everything. So just to give to hold it, the soft tissue, I gave a figure eight kind of suture material, and that patient, excuse me, patient turned back not well within the time, because the suture has to be taken away within 5 to 7 days. You are not supposed to leave the suture for such a long. I use PTFE sutures. I don't use those any other biomaterial which can create a lot of infection. But if any suture, whether it is PTFE or nylon or anything, or silk, never use the silk suture. In India, I've seen a lot many people using silk suture into their implant practice. It is the worst suture material. If you do not get a cytoplast, the PTFE sutures, then stick to 40 or 50 nylon always. So it was a suture abscess because patient never turned. So when I took it out, it took a lot of time to heal. And that is why I used the laser, diode laser. I have a diode laser. I don't have a hard and soft tissue laser. So I use a diode laser to gently, I called him 3, 4 times and I used at a very low settings. It has to be 1.6 watt or 1.8 watt, not beyond that. And I got a good result with the laser. And this happened because it was a suture abscess.
And the next question is asked about sausage technique in labial bone defects.
Yeah, sausage. I do a lot of sausage. Um, I have been trained by Professor Istvan Urban, and he's my mentor also. And I have certain cases, but in this anterior aesthetic zone, because we were talking about immediate, because that goes into the delayed placement. I had one case which I could have shown it to you onto this, but you can always tell the doctor who has asked the question, he can contact me on my email. I'll show him the case. Their sausage technique is very, very good. But when you are doing sausage technique for in three wall defect, when you get three wall defect, there is no need to do sausaging. Right? You can just do the contour augmentation. You can place the implant because from the buccal and distal side, there is a lot of bone which can migrate into that. And so you have to do a autogenous bone on top, and then on top of that, uh, xenogenic bone. I prefer demineralized bovine bone. And I give a contour and give a double layer of membrane, which is the Boozer technique, and I close it in maxilla. But if you are getting one wall defect, when there is no wall, just one wall is remaining, you cannot do a simultaneous placement. So in that case, you have to stick to first create the bone and the soft tissue, wait for 6 to 9 months, let the baby be born, and then place the implant. So in that case, definitely sausage technique, you have to have bone tacks, you have to have a very stretchable membrane, which I prefer is Geislich. From Geislich, the BioGuide membrane is there, and I use BIOS and 50-50. So Istvan says you have to get the autogenous bone, especially the cortical shavings. So create a larger flap and then get the cortical shavings, create a coagulum, and then mix it 50-50 with the xenograft, and then pack it up like a sausage. You have to push it really hard inside and leave it there for 6 to 8 months, and then re-enter. So sausage is very good, very predictable, but again, you have to learn it. I went there. I went to Budapest with my colleague, Dr. Wabo, and we went there. We stayed there for 2, 3 days. We attended the conference, world conference, which he had hosted for the first time, hard and soft tissue regeneration conference. And then we attended his uh, uh, hands-on workshop, and we learned it. And then I came back and I started doing it. Any other question?
The next question is asked by Ojas. He asks that which allograft is best to use.
See, again, when you are using an allograft, normally many countries the use of allograft is prohibited because allograft you have to learn that what is the source. So allograft is from the same species, and then Is it cortical? Is it cancellous? It is corticocancellous. And the bone bank has to be really reliable. And chances of disease transfer is very much. So bone grafts, allografts are like FDB, freeze-dried bone, which I don't use. I use DFDB, demineralized freeze-dried bone. So demineralized freeze-dried bone, which I use personally, and I always tell that when you are using a biomaterial, always use it from the company which has registration in your country. Because if it is not registered with the government and your patient goes to, because that would create a legal issue, and patient goes and complains into a consumer forum, and uh, if you will be asked that which material you have used, and if it is not registered, then you are in trouble. Whether it is implant, which has to be placed inside the mouth, any material which is you are placing, it has to be registered. First thing. Second thing is the religious consideration is very important in India. You cannot place bovine bone, the cow, holy cow, into Hindus. You have to get a consent. You cannot place porcine, which is coming from pigs, into a Muslim. You cannot place anything into a Jaini, because Jain person will not allow you to place any bovine bone, any porcine bone, any equine bone. He or she will be ready only for alloplasts or sometimes the autogenous, your own bone, or they will not allow. So that is very important. I come back to the question. I use DFDB, that is demineralized freeze-dried bone, and that comes to me from Bottis. Bottis is being taken care by Stroman, so they have this uh, uh, the the allograft with them, and I utilize that in case if I have to use a human bone.
And our next question is by Danish. He asked, what sutures you advocate for aesthetic region in different scenarios?
In let me tell you, in anterior aesthetic zone, if you are dealing, if you are placing a suture onto the papilla, you have to be very careful. You have to go for 5O or 6O sutures. So if you are not using loops, the magnification into your dentistry, then you are like, you have a myopic vision. You can't see the finer details. So loop is very important. I use loop, and then you can use those uh, uh, sutures which are there, finer sutures like nylon 50 or 60. And if you are using it on the papilla, you have to take it out within 3 to 4 days to prevent the scar formation. But when I'm using it for my augmentation procedures, then I use PTFE sutures, which is by Cytoplast, and it is the best in the world. And I use for my horizontal mattress sutures, I use 3O, and for others 5O. And for finer, more finer papilla attachments and everything, I use 5O, 6O nylon, but then they have to be taken out. Morris Stegman, the another guy, he's the one of the big guy into soft tissue augmentation, periodontist. He always says that never ever leave your sutures, especially on the papilla, for more than 3 days. Call the patient third day back and take it out. Because in anterior aesthetic zone, the scar formation is the worst thing. So that is why all those people in the world, when they are doing surgeries, they design their flap that into the widest grin of the patient. None of the soft tissue is visible, because always when you do surgery, there will be a scar formation.
Sir, next question is asked by Dr. Bakiullah. He asked, what's the protocol for the patient who has taken bisphosphonates?
Yeah, there is a lot of study into the bisphosphonates, and then they say that if a patient is on I mean, like rheumatoid arthritis and arthritis patients who are onto bisphosphonates, they should not be given because implant placement, because there has been studies showing a lot of failures with the bisphosphonate. But let me tell you, the recent now people have started considering the vitamin D deficiency. So the most of the black population, like we in India, we are more black. We are more black. We have a black or brown skin. So most of the Indian population, people have got a lot of sun, but we are unable to synthesize the natural vitamin D. So many of the Indians, when they go above the age of 35, they are at loss with vitamin D. So when you are thinking of placing any implant into 30 plus people, always prefer checking their vitamin D concentrations into the body. And if it is found less than 30, then definitely go for supplement. Put your patient onto vitamin D with calcium, not alone. With calcium, because synthesis is very important. It will not synthesize on its own. It needs calcium. So with calcium and then extra sachets of vitamin D weekly initially to recover, and then after two months, something like that. And vitamin D deficiency has a strong correlation with the implant failure. And bisphosphonate, you have to be careful. You cannot normally I don't place implants when a patient is on bisphosphonate therapy. I don't do
And next question is asked by Shubham. He asks, sir, which graph you use in your all cases, the cases you have shown?
that. See, there is no one recipe. There is no one recipe. You have to according to the case. If you have to do contour augmentation, I mostly prefer um, uh, demineralized bovine bone, xenografts. And xenografts in India, the best one is uh, from Geislich. I'm the KOL for the Geislich, so that doesn't mean that I use only Geislich. I use Ceravone also from Botis. And if a tooth is available, I'll always prefer dentinal graft because it is autologous. And let me tell you what is the difference between when I have seen the histomorphological sections of my own cases. When you use a dentinal graft, what happens? The new bone formation around the graft particles, there is an ankylosis. Why there is an ankylosis? Because the host bone recognizes dentinal graft as its own. So there is very little inflammatory response. And because of that little inflammatory response, the ankylosis happens if you see the cross sections of your histomorphological studies. But when you see xenograft or any other graft material, xenogenic or porcine, xenogenic porcine or bovine, because initial response is inflammatory, so the interface of the newborn and the graft material into the histomorphological studies, which we see, is fibrous. So that's a big difference. Uh, Most of the cases I do autogenous and uh, demineralized bovine bone, sometimes porcine also, but I have to be very careful about the religion of the patient. And I don't use alloplast. I don't use it.
Next question is asked by Siddharth. He asked how to prevent flap dehiscence.
How to prevent dehiscence?
Yeah.
As I said, planning is very important. So diagnostic CVCT is very important these days. Initially in India, CVCTs were not there, but now every city has a CVCT center. a good CVCT center. So buccal bone mapping is very, very important. And if you have to see that where is the fenestration is there, if there is a fenestration or the buccal bone thickness is less, then you, as I said in the Vivian Choppy et al. Study, that if the buccal bone thickness is less than 1.5 millimeter, you may get a dehiscence of vertical dehiscence of 7 millimeter from the crest. So in those cases, you have to decide it before that what is the thickness, and if there is not enough, because every implant placed, you should always remember the thumb rule that there has to be 2 millimeter of bony housing all around the implant, circumferentially. If that 2 millimeter is less than that, then you have to consider grafting, whether it is internal grafting or external grafting. If you get enough bone, then dehiscence, there is no chance of it. But if there is no enough bone, you have to do GBR, and that is the only way you can prevent the dehiscence on the long run.
All right. And our next question is asked by Dr. Gunja. She asked, Sir, is this a good treatment possible for asthma patients?
Asthma patient, there is very little. I don't think there is any problem with the asthma patients, but if they can be controlled and you need to have a lot of um, they are on different medications, so you have to consult the physician. And in asthma patient, I believe only one problem can be which can be hinder the implant placement is if they are on steroidal therapy, because many of the chronic asthma patients, they take steroid with their bronchodilators. So in that case, because of the patient's immune responses on the lower side, there could be chances of infection, but I don't think anything else is. The bone quality has nothing to do with the asthma. I don't think so.
And the next question is asked by Dr. Karan. He asked, any other substitute for the managing monomer content of flowable composite?
See, if you are using chair sides and you are using a flowable composite, you have to reduce it by placing it, by giving it a heat treatment, because there will be loss, uh, leaching. So other thing is that if you have a lab within your close proximity which can deliver you a peak material which is more biocompatible. So if you can get a temporization done, if you have incorporated digital scanning and digital dentistry in your practice, things becomes pretty easy because you can take a scan, pre-scan, and then send it to the lab, and then they can design it beforehand. And when you place, everything is ready, and you just place the peak material temporary prosthesis onto the patient mouth. But that is possible only with a digital setup. If you do not have, because I believe in India still, uh, most probably 10% of the dental surgeons have digital scanners with them because it is a costly affair. So I am talking on the perspective of general population who are doing implant. So if they are lacking into this armamentarium, how to do that? There has to be a way. Not everybody can have a, a digital scanner in their practice, because it starts from 13 to 15 lakhs to 35 lakhs, and many, there are hordes of it. So in that case, you have to stick to these things. And when you are sticking to these things, you have to take all these things in consideration, like giving a heat treatment, and you get it. It's nice. I get good results out of it.
And next question is asked by Dr. Karan again. He asked any other alternative management of the soft tissue irritation because of the flowable composite?
Any other means what? Like I was unable to understand because if I'm using a flowable composite, I said I have to give heat treatment, nothing else.
And next question is asked by Dr. Richard. He asked, what is the most popular implant system in India now or in USA now?
It depends upon the patient's the doctor's own choice, but you won't believe I had to do uh, in my practice. I started with few systems. I started from Biohorizons initially, and then slowly I added up more than 15 to 16 systems in my practice, almost 20 systems, world class. Then I slowly came down, closed in for certain systems. Like I use Strawman. If I have to go for tissue level, I use Strawman. Then if I have to use uh, ceramic implants, then I'm using Bredin. Then if I have to use normally for a general public who cannot afford, I'm like in a normal range implant systems are like um, Cortex, but it has to be conical connection. And then I have uh, Dentium, which is quite popular in India. Then Pioneer is a very good implant from Spain, which I use. And then Megagen, I said, if somebody asks me which is the best implant system in the world, I will say Megagen. Megagen any ridge, because it has one good thing at the collar, at the neck. It has a constricted collar, so it never gives any kind of uh, compression onto the cord, onto the crest, and that is very important. That there has to be no. You should always remember that your initial stability should never come from the crest. It has to be apical, because if there will be a pressure on the crest, you will lose the bone. And normally, you see a V-shaped notch when you load the implant, or sometimes even before loading, there is a V-shaped notch we find after 6 months or 4 months or 3 months. So this is very important. If you do not have this kind of design, because it has a longer flanges, then you have to use countersink drills or cortical drills to create a passive atmosphere onto the crestal region. So these are the implant systems which are very popular. Strawman is a big, Bioneer is there, Cortex is there, Tension is there. Uh, I use Ankylos from Dentsply, so this is also world-class system. But Dentsply Ankylos has to be used by an experienced user. A younger generation should not go for it, I think.
And next question is asked by Dr. Wafiullah. He asked, could you please elaborate double membrane technique of Daniel Buser?
See, double membrane technique, he need to listen to me on my another lecture, which is on hard and soft tissue regeneration, especially because in anterior aesthetic zone, double layer membrane is like I normally prefer taking a 30 by 40 membrane. And then with that membrane, I cut it a strip of that membrane beforehand using. And then when I adapt the membrane, uh, on top of that membrane, I place that strip again. So it's a double layer. And then Boozer has this sandwich kind of contour augmentation. He does a sandwich technique. He never mixes up 50-50 auto bone and xeno, demineralized bovine bone. What he does, he packs it up with the exposed area of implant with a autogenous bone, and then on top, pure xenograft, demineralized bovine bone, purely. he never mixes it up with anything, because he says, I don't want any conversion onto the outer aspect, because I want to maintain the volume. So that is why it is known as contour augmentation. And then he places the barrier membrane, and to my surprise, he never even stabilizes that area. He never uses a stabilizing suture, especially in the maxilla. But if you're doing it in the mandible, you need to stabilize the membrane. So he just covers up that grafted area with a membrane which comes from the palatal side to the buccal side. And then he places that strip on top of it. So that delays the resorption of the membrane, because normally guys like BioGuide resorbs within 6 weeks. And that is, it has been very nicely, study has been done by Professor Istvan Arban, that he says you just don't need anything more than 6 to 8 weeks, 8 weeks, because graft material is already stabilized till then. So you do not want your barrier membrane to go beyond 6 to 8 weeks. And your barrier membrane has to have a very nice porosity to let the vascularization which is coming from the periosteum. So early resorption, long-standing membrane resorption is not advisable as per his technique. I don't know. Many people they like it. The membranes which last for more than three months. I don't do that. I get very good results, and I do a lot of sausage technique and contour augmentation, and I get very good results from out of it.
Very well explained, sir. And I think we are running out of time. Any other questions will be answered in comment box only.
Okay.
So, on behalf of Global Interdisciplinary Team today, I thank you for taking the time to speak to us today on very important topic, do's and don'ts of anterior aesthetic zone. And thank you, sir. It was really a great session full of energy. And at last, sir, do you want to say something, some words?
Yeah, I would like to congratulate Dr. Kianor Shah and for his great efforts. He has put 100 dentists and as a team, because I'm the one of the members of the board also. So we do discuss a lot, and I would request all the dental surgeons around the world to listen to uh, the webinars which are going to be followed, especially today. Samuel Blian, and he's a very good friend of mine, and Dr. Arun Garg, who has amazing work, a lot of publications. Listening to him will be and it's a great pleasure and honor for all of us. I'll be there to see him, and I thank all our team members, and I want to thank Rakesh and you and your team for wonderfully hosting this program. And thank you so much, and namaste.
Thank you, sir. So we'll be back with the next session in few minutes. For more information regarding certificate registration, speaker schedule, visit www.gomha.org. Till then, stay tuned. Thank you.
Bye bye.
Bye-bye, sir. We will be ending
You
with
can
the meeting.
yeah, end the meeting. And I want